Am I audible or not?
Yes, ma'am, you're audible.
Okay, thank you. Professor Rao, are you there? I guess. Hmm. He's present on board.
Hello. Yeah, sorry for the delay.
Yes, sir. Okay.
Thank you.
So we can start, sir. Next
Yes, we
session.
can start. Yes, we can start.
Hitesh, share that screen.
Yeah, I was just returning to my desk. I saw your voice. Then I muted. Okay.
Okay, sir.
Thank you.
So, dear participants, again welcome you on the last session of this program. Technical session, we can say. Then we have a valedictory session, and this session is on public health issues and their analysis. And again, we have with us Professor Arni S.R. Srinivasa Rao. Sir, now platform is all yours for your session. Over to you, sir.
Thank you. Thank you,
Welcome
Dr.
again,
Rita.
sir. Yes, sir. Thank you, sir.
Thanks a lot for the organization. This has been wonderful. This is actually continuation, in a way, continuation of the previous session, lecture number 11, where we learned about the graphical network models and how they are utilized. And now the current talk will be, as suggested by the organizers, it will be on the COVID. And we try to understand this again, a different kind of models you will see there. And then how we can utilize that kind of knowledge for understanding better the COVID spread and COVID identification. Let me start my slides. So as this thing mentioned, this will be on the COVID. So there are two kinds of models I will explain. First, I will touch on the artificial intelligence models for the COVID, then followed by the model for underreporting of the COVID data. So first, let me start with the model for AI. So I usually, I build mathematical models for epidemics, but when COVID started in 2020, beginning of 2020, lot of confusion was there. If you all recollect, if you all remember what happened that time in January 2020, a lot of confusion that whether the virus will at all cross the China and then will reach other parts of the world. There is no sure that whether to cancel the flights. A lot of confusion was there. So it was not sure whether the spread will be there for other countries or not. At that time, just if you take back all your memories, 2 years, 2 months before, then at that time, I thought that developing a mathematical model for spread may not be the right time. So I developed a model because prior to that also I have been working on the AI and the interface between the mathematics and the AI, artificial intelligence. I have been working because for me, artificial intelligence is closer to the mathematics than to the computer science. And mathematical foundations are properly done for the AI framework, then the implementation part, computer science will come. That is what I have been promoting, and I'm working on the various kind of things prior to the COVID itself on the AI. Then I thought that AI, using an AI, the identification can be done much better way. And then I developed a model and then equipped it with the AI for that. So this will be first part of the talk will be on that. Few slides very quickly go through. And then I asked my clinical collaborator, clinician, about the symptoms, other things, and whether he is interested to collaborate, then instantly agreed. So once the model done, methods are ready, then he joined for the symptoms part, and then we jointly published. And this became first article worldwide to identify COVID using the AI framework. That came in February 2020 when there are only 5 cases were there in the US at the time. Only 5 reported reported COVID cases. At that time, we published this model. So identification, the title of the article, identification of the COVID-19 can be quicker through AI and using the mobile-based survey. And this article inspired for worldwide many such works, including this inspired Arogya Setu app in India. So how this model works? So it is covered by the. I want to thank various media all over the world for covering that, and that gave me opportunity also to interact with the various other industries like airlines industry. They all consulted, and then I was lucky. So how this AI model works in two phases. I will go in again a very simplistic, easy manner. The summary of that first phase: collect the travel history of all the individuals who through the mobile phone based survey. And the second part is to assess this, the analyze the data at the back end in the hospital. First part is that, no, sorry, first part is collect the travel issue because the quarantine period. Those who are quarantined during the quarantine, people are suggested to stay back at home, and then everyone will be sent a mobile-based survey through an app, and then that those will be analyzed at the back end at this hospital wherever the AI is installed. And then those individuals will be given information whether to go for a proper testing or not. They don't have to go through. So that part will be decided by the AI, artificial intelligence framework, and then the individuals will be either taken by a mobile-based vans or they will be tested at home, the ideal. And then there is no duplicacy, like one individual responding, other individual is going to the hospital. That is also, so they will be given some sort of identification, individuals who responded, and they will be further followed up by the actual testing. So this method will simplify the rush to the hospitals. Also, that's an advantage. Other advantage is that proper identification and through their based on their symptoms and travel history and other factors. At that time, I used this WHO and CDC's guidelines of the travel history and what are symptoms because no one knows at the time 2 years before. So graphically, if you see that, suppose this is a geographical region, some region, and these are dotted lines are the house and circles are the individuals within a house. And every individual houses and each individual within a house is given send the mobile based survey, and then you see that here blue color dots are the individuals who responded to the survey, and then yellow color dots have not responded to the survey. They have not responded, and then you see that obviously those who have not responded, some of them also could be positive. The red circle indicate they are positive. So the red one is identified. These are all positive individuals, potential to have positive individuals after the back end artificial intelligence framework has been suggested to the individual to the based on that they are suggested to go for further testing or not. And these individuals are the individuals who have been are not no need to they don't have to go through the individuals. They don't have to worry about their status because the model suggests that they don't have risk of having COVID. So here you see that those individuals who have responded only can be processed through the AI model. Those who have never been responded to the mobile-based app, they would never be ascertained whether they are positive or negative. It's not possible. No method or no model, unless the individual are willing to come forward, there is no way that they can be tested for positive or negative. So this was about 2 years before the around February 2020. I mean, so exactly 2 years before when we published that. So this stood as a gold standard for all the AI models on the COVID identification. So my co-author is a clinician. He is a clinical infectious disease doctor. And then all the things again I will send the article. But then there is one theorem is being proved here in this article about the what is the chance that the individual responded or been an individual identified has been responded to the survey, that is n1 n by n square. Let me explain that. If there are n individuals in a region, then the probability that small n1 cases are identified through the AI framework, given that there are n individuals responded to the survey, small n individuals are responded, n1 cases are identified, the chance is n1 n by n square. The chance that, because what is the chance they may we are sending the surveys, but what is the chance the identification is done among the respondents is that we need to know. So this will help that. This will help us, this number. Just for, since this is a course on stochastic process, I thought to, usually I don't in the other talks and the public health talks, I won't give any idea. But since the students are having good background, also been with discourses on that, I thought of giving you a proof of the idea of the proof. So total, let there be n and m are the individuals in a region, individuals in region who have responded and not responded. The total population in region is divided into two categories only, either responded to the survey or not responded. N plus m makes the total population. Then let's set you be the individuals who respond to the survey. U1, those who responded, you just mark them U1, U2, UN. Those individuals not responded, V1, V2, EVM. Okay. Total population is N. U and V are the set of individuals who have responded and not responded. And then U1 be the individual among the U1 be the individual, U is subset of U, where U again who are identified as the possible cases. Among the respondents, you are the individuals who are identified as by the AI model that they have a risk of having COVID. They are U1. Again, you mark them a UA1, UA2, UAN1. From the, see here, U1, U2, UN, among them in some order, UA1, UA2, UAN1, which is subset of the individuals who have responded to the survey. So then the two events can occur in that case, in that situation. First event E1 is N1 out of N responded cases are identified through the AI model, or N out of N cases have responded to survey. So those individuals have responded to the survey, and those among the respondents, those who are identified through the survey. Two events and can only occur through that entire process I explained through the graphs, that figure. So only two events can occur. Hence, the probability, condition probability, this is condition that E1 given E, using the information UV, U1, E1 given E. So condition probability, as we saw that A1 union A union B, using that formula again here, the condition probability that N1 cases identified through the AI model is N1 multiplied by N square. Because out of that, N1 individuals have responded, N are the individuals, N1 identified, N are the individuals who have responded, capital N is the total population in that region on which a survey has been conducted during the quarantine period. So this summary, that is our summary, and later this method, the worldwide, lot of regional languages, English dailies, all over the world, they reported this study, what we published much before the COVID actually really spread. These are including our major dailies in India like Dainik Jagaran, and Hindustan Times, Times of India, Express, all the major news articles, newspapers India covered. This later inspired for Arogya Setu app, and then that's how that's what I came to know. And then probability of identification of COVID can be demonstrated how we can identify the COVID. And then after that, the underreporting, all the technicalities one can read into the art journal, because we can. This is a public health seminar, a public health lecture. So underreporting. After that, then the COVID started slowly in the March. This is that previous study was in February. Then March, you see that already Europe, the cases, the cases have been spread in the Europe, and sorry, the cases have been spread in the Europe, and the lot of confusion about what would happen to other part of the world. And by February end of February, the 8 to 9 countries in the Europe, like France, they all, Spain, Italy, they all faced severe COVID cases. I mean, the larger number of people are piling up in the hospitals. So then me and my collaborator Stephen Kranz at Washington University, St. Louis, we both collaborated, because prior to that also I've been collaborating on various other things, and for immediately we thought we should do something for the COVID. So we published an article on underreporting, how the underreporting is, how many cases are not being reported. So we applied wavelets for that particular this thing, and then we come up with a first underreporting study among the 9 countries in the Europe, 8 countries in Europe, and then the US. And also separately we did for India also the underreporting rate at the beginning of the study, beginning of the pandemic. So then we know that the actual pandemic, we all agree that the actual pandemic preparedness, government have to prepare on the real pandemic happening, not on the what is being reported, because reported need not be always complete. We cannot just base it on the reported data, we cannot formulate a policy. We have to formulate a policy based on the control policy, based on the actual things on the ground, what is happening on the actually the transmissions happening. We need to bring a policy for that. So then what do we do? Again, the summary of this thing, we considered these countries: China, Italy, Iran, South Korea, France, Spain, Germany. And then up to the March 12, 2020, almost 2 years before, that time, you see that only except India, very, very low cases, the reported cases, and China only reported, that time 80,000 cases by 12th March 2020, 2 years before. So today is 18th March. So 2 years before, the data there, and Italy, 10,000 in the decreasing order, then the 8,000 in Iran, South Korea, 7,000 France, Spain, Germany, US. Then the history, by the time, even when we collected the data available online, we still don't know how the other countries would would fare. Then the range of the first peak, we considered what is the first peak occurred, and then we are not sure whether that peak is a real peak. When we know that peak was not real, because several peaks occurred. So sorry. So date ranges considered January 1st, China for Jan 22nd to February 4th, and some countries up to March 9th and March 6th, various different intervals, except the US. US has now first, this peak has not reached by then, only 874 cases. Later we showed that these 874 were the only reported, but actual cases were 5,000 at the time on the ground. Again, model-based estimates. Truth would never know, only the model can give you. If the model is accurate, model can give you some picture which may be close to reality. Other factors, what are other factors considered apart from this data? We consider the population density, urbanization, what level of people living what fraction of people living in the urban cities and the rural areas, and the daily new cases, what is the daily reporting of the new cases, and the proportion of the population in 0 to 14, children 15 to 64, 65 plus. Ideally, we should have considered 0 to 18, but then the data, the worldwide data was not available they are only available under these age categories. World Bank data or other data, common data. We need to use the same set of data for all the countries. So we use this. So this is the starting again. Let me quick repeat. So countries and the cases up to there, date ranges, other factors considered before. And then same as in Italy, 1 in 4 only reported. And Iran, 1 in 34. South Korea, 1 in 4. France, 1 in 5 reported. Only that means 1 only out of 5 cases, real cases are reported. Spain, 1 in 53. Germany, 1 in 3. And US data was incomplete, so the 1 in 406 was not very accurate statement because that the data did not reach the peak in that period, and only the sample also the whatever reported so low. And same time India also this that time later after this study we published an Indian data, which and then that came also in the various media reported. So at that time saying that 1 in 4 by end of March 31st, 2020, 1 in 4 cases in India was reported that time. Just we are end of the first major lockdown, but that was very successful. So what we did was, we used the wavelets and using our Fourier transformation showed that how these impact of the model-based report. So Italy, you see that previously the reporting was almost 1 in 53. That's why it's bad. There is a lot of difference between the reported actual data. And same as Germany, you see the almost good match because reporting was almost close to the 1 in 3. So that is a fairly better reporting was done. And then Spain also almost bad reporting at that time. If the model is accurate, that was the model between model reporting versus the accurate reporting. So as I mentioned, only there were 90,000 cases in the mid March, but whereas reported only 4,000. Only 4,000 reported in the middle of March in the US, whereas 90,000 according to the model by Kranz and me, it is only 4,000 only reported. So that's why you see the discrepancy between the wavelets showing the discrepancy between the reported and the actual. And then later the predicted hospitalizations. So models, these applications I just want to give you an overview, the models, how. So we predicted the hospitalizations in the US. And then you see that, the lower estimate, medium estimate, and the higher estimate. Three kinds of estimates are given about the hospitalizations, non-ICU hospitalizations, and ICU. So these are the hospitals which are non-ICU, and these are ICU related hospitals predicted. So these are all again given report to the various state. I mean the when they consulted here me and then provided all these things to the time to time various things, how the hospitals have been filled and all these things. So we three kinds of estimates are given. Medium range under what if the other day you saw in HIV also, if the spread is controlled, what would happen if the poor kind of quality of controlling or understanding the reporting or what will happen, and then the lower estimate. Yeah, of course, this is the various news reports. Sorry. So this is the summary of the previous slide was only the news articles. I don't want to, yeah. So this is the summary of the COVID again. COVID models.
Sir, may I ask one thing?
Yeah, please.
Sir, in the previous slide, you have shown the estimated values of the patients.
This one?
Yeah. In this slide.
Yeah. This is a model based.
Yeah. Which model was used for estimation of this value, sir?
Yeah, the model description not given. So we use differential equation model here for various compartments, and then the all kind of the age groups. The population is divided into 3 age categories: 0 to 14, 14, 15 to 64, and 65 plus. And then the total population is divided into categories, and then how the population spread occurring within the population using a differential equation model, and then the components of hospitalizations, at what rate hospitalizations would admit the patients, and then the severity based on the three comorbid conditions like hypertension, diabetes, and lung-related diseases. Those who are having that, they need ICU admissions. Other patients do not need. They may require hospitalization, but they don't need ICUs. The same kind of data also I was time to time sending to the various sources in India about that, the hypertension, the fractions. So I was the first one suggest there in the policy that 65 individuals should not come out of the home. That's a model-based policy. So that later also I saw that various announcements done, and India also 65 individuals have higher risk of death. So if they acquire, so controlling.
Actually, sir, in COVID-19 estimation, it was observed many people in the world were estimating. The
Mhm.
predictions were there, but
Correct.
very difficult to cope up the observed values. So it was very difficult that time. Whomsoever
Correct.
was whomsoever was estimating the actual values, they were behaving in a such a way that nobody was able to predict actually any model, such model that it goes very close to the actual one. Yes.
Correct. You are. I agree with you. I agree with you very much because everything happened so quickly.
Yeah.
Everything happened so quickly, and there is no, because during the quarantine, that's the reason. The idea, I thought you are right. That's the reason initially you saw the AI model. I thought that identification is more important in this case, identification of the cases, than the spread, because spread you cannot control because no one knows how the spread. Somebody says airborne, somebody is saying not airborne. Agencies like WHO are having a lot of confusion on the spread of the disease.
Yeah.
They sometimes told that airborne, again they withdraw, again they are telling airborne, non-airborne. Lot of confusion was there.
Yeah. Yes, sir.
So luckily we all passed through that stage, hopefully.
Yeah.
And the 2 years have been spent. Everyone's life, 2 years have been gone. They don't remember how in their life 2 years have been spent.
Yes, sir. Okay, sir.
Welcome. So snapshot of the overall study. In the here the wavelets are being, apart from differential equation, the wavelets have been used, and the AI model, previous one network model, and the stochastic model you saw HIV, differential equation. So there's a lot of things the students, you all have been exposed here. The way it is designed is to inspire you all to take up the research, and also teaching. When you teach also this thing, I hope this is a hope. This is not the unique way. Whatever way we three organizers we thought, we have conducted the way we thought may be beneficial for you all. The design part, as I mentioned, were very well done by Professor Kumar and his team, Professor Redu and others. So that way, this has been. Otherwise, I would have purely given on only stochastic models for end of the day, all the theory examples. But then this way, we are given a much more wider range of things, and hospitalizations. Hospital, how to use the hospital data, how to collaborate with the non-technical people. That's important also, because practically the science means it is not just math, and mathematics is more easier than any other sciences. In fact, medical science is a much more difficult biological science than mathematics, because mathematics goes by rule, and it is so easy. For me, among all the four basic sciences, mathematics is the most easiest. Whereas you see the biology, our under medical sciences, our understanding is not. I told not just today, many other talks also. I mentioned this also. That when they asked questions about a lot of, recently I gave a talk for the NCERT school kids from 9th to 12th grade. There also, when parents asked the question, I told among all the four things, basic sciences, the school kids to learn, mathematics is most easiest, and biological science is more toughest. In a sense, in the biology we try to understand what is existing, but we have not created it. Whereas in math, everything is we created. So we means the human created it. So we able to understand one mathematics. Maybe it is difficult for one other mathematician whatever they develop, but it's not impossible. But biological things are impossible to understand beyond what we see. So which you cannot see, or which we never created, is more difficult, or which we created is difficult. Obviously, which we never created. Something existing you are trying to understand in biological or medical sciences. So it is important to collaborate, important to develop very good collaborative environment, and help you are bringing a mathematical insights to help the real science, how the real science benefits, and they are being benefited by your intuition here. Something which they cannot see, you are trying to bring some intuition into the model. Yeah. Any questions? Welcome.
Sir, I have a question.
Please.
Sir, can you please tell how and where we can use queuing theory, especially queuing theory in healthcare management system?
That's a good question. Queuing theory is a very powerful tool. Healthcare management, especially the yeah, this is actually now I think after you ask, I think that hospital management queuing theory plays a bigger role. Especially Professor Kumar given a wonderful talk other day on the queuing theory and telephone mobile based network. Hospital rush in the hospitals, especially during the COVID, and what rate the hospitalization. In fact, continuously over the last 2 years, I have been giving regularly the hospitals the how they have to prepare for weekly. Every week, I have given predictions for the clinicians and the hospital managers, number of syringes they require, number of beds they have to be prepared for the COVID. So that way, that is where the queuing theory can
Okay.
be applied. One of
Sir,
that's only one area. There may be many more, especially the each category, each disease category, they can decide, they can see in advance, and they can someone whoever asked the question, you can go to the nearest hospital and then build a model, original model based on the queuing network, and then say that next 1 year you predict the various disease individuals who come to the hospital.
okay.
Then
Sir,
compare the data after end of the year, and then see that if the model doesn't work, still fine. You can retune the model following year and then finalize the model based on the 2 year data. 1 year, one or maybe 6 months you collect the data. Better to 1 year because the year season start. All the seasons are covered in a year: rainy season, winter season. So better 1 year the data collected and the tested model being developed. Second year test the model.
okay.
Then it is useful.
So, sir,
Yeah.
okay, sir. If we do not have any data set, like if I'm not able to get any data set from the hospital because of their privacy policies, then what should be the procedure? Like, should I uh, go with my guide and then, like, by the form that you said that try to contact them, like this
Correct.
way?
Yes, correct. Correct. It is through that one has to go through and through a proper channel. That way, everyone is safe. Tomorrow, you as a student, if you are a student, if they directly give you the data, suppose say you are the hospital in charge, you are a chief medical officer in the hospital, and I am a student. I come to you for permission. Naturally, if you give me the data, you have to protect yourself. Some I may not use the data properly, so you are at risk. So naturally, it is you as a chief medical officer. Your role is to safeguard you misuse instead of misusing. Natural, it's a natural doubt. So you expect me to come with a proper channel. So my authorities they come approach you and then they share the data. It is safe for everyone. It is not between the
Okay.
trust or distrust. It is everyone need to be safer. Safe in a sense, the patients have to be safer. Tomorrow, the patient data, they have to worry that suddenly you go to some neighborhood and oh yeah, this particular area more risks. You may want to, without data being properly analyzed, you may want to share the information to the public. So that is more
Yes.
dangerous, isn't it?
Yes.
That's why you go through the proper channel and attend, and then you can share that you attended these courses, and then you are know about the ethical values, all these things, and then share them with them, and so the certificate or whatever the I don't know various ways. It has to come. Some interest has to come from hospitals also. As I mentioned, various kind of my mathematical models.
Okay, sir, is there any website from where we can download publicly available data sets
Yes, you can.
like
I think some of the governments also release. You can see various state governments in India. They are putting the data online also. You can download them, and then that's only what happens. most of you, my suggestion would be try to do something which having a real value, not just a
Yes, sir.
stochastic or statistical value. The stochastic statistical value means what? You predict something after past data and then tell that this happened in the past year. The beta values are appropriate. So your beta values are not even able to control the epidemic in the past. So try to do something which are, I mean, for PhD purpose, why it is fine. But when you are faculty, this thing, ideally better to build models which are realistically useful, not rather than parameter fitting purpose.
Yes.
Sir,
That
I
way,
Okay,
yes.
sir. I need one more help. Actually, I have developed a model.
Mm. Yes.
So I want that you please share that data set with me so that I can improve the accuracy of my model with that data set that you have used in deep learning
Mhm.
with infertility.
Yeah. Sorry, I'm still today. Actually, as soon as I finish this session, I'm going to search somewhere. The wherever with my collaborators. I'm going to send this one to Professor Kumar. Did you receive all the HIV? Did you see that in the HIV articles? Did I include that the infertility or not?
Sorry, sir.
In the list of articles on HIV, did I include the infertility article?
No, no, sir.
In that list of articles you received for HIV, was the infertility article was not there, isn't it?
Yes, sir.
It was there. Can you check? I sent several articles in that.
Okay, sir. I will check it.
Yeah. Otherwise, also today I'm going to send that again. I could not locate other day when I wanted to download. It was not. It was asking me also to pay for downloading.
Okay, sir.
Yeah, I will send for sure today itself.
Okay, sir. Thank you so much.
Welcome. Yeah, this is what the purpose here is. As I mentioned, this kind of GAN courses was not conducted since the beginning of the GAN. Practical applicability of the. So please use this course for realistic model building
Sir,
in the whatever area you have been working.
sir,
Yes, please.
if possible, can you name and one or two sites for getting the data from where we can get the data?
The other day, as I mentioned, go to the WHO website and look for data WHO data within the WHO, and also Ministry. If you health data, our Ministry of Health, has a lot of online data. That is mohw.gov.in.
Sir, NFHS data is available online. NFHS data. Is it possible to use that data?
You can use, but sample is too small. NFHS, the sample is very small. One can use it if you want. One can use. I mean, any data.
No, sample is not. That is in many lakhs, sir. Previously, it was 6 lakhs population. Now it is more than that also. In 15, 16 NSFS. Now they must have increased up to maybe 8 lakh or so, or 9 lakh. Previously, it was 5 to 6 lakh.
Okay, previously 5-6 lakhs. Okay, I don't know. I mean, initially if sample is enough sample, because the NFHS design was done for the family national and
yes, sir. National Family Health
family
Survey.
health survey.
Yes, sir.
Family
National
health
Family Health
purpose. It was suppose say, yeah, this is important. The point here, I want to make one comment here about which is, although the course is not about this, but then indirectly related. When you you are using some survey data. Survey data will have a design. Like in previous session, somebody asked a question. Survey, when you conduct, suppose hepatitis C survey, the survey was conducted on the seroprevalence. Suppose say the purpose was the survey design. Design means here how many samples to be there, and what purpose to be there. All these things. That's a design component. And within the design, when you have a hepatitis C survey conducted, and after the survey designing was done based on the age, and then their network sharing, and suppose say on the based on the gender, suppose say, and then you also that's a design, but during the survey you collected on the smoking behavior, financial status, their travel history, their what type of clothes they wear, their home has any gas cylinder or a regular chula, all these things. Suppose you collect all the data which are not design is not used for that, but design used for other purpose. Then after the survey conducted, your sample size may be 1 lakh, bigger sample on the injection drug users. But using the data, you have other data on the gas cylinder or in home, the financial status. That data you cannot use it strictly for conclusion, bringing any regression based conclusion, because the design was not done for collecting that kind of data. The design was done for something else, but you are as a byproduct, you collected some other data. So byproduct data cannot be used in a strict sense for bringing a regression models, because that was not part of the design. Is it clear? This is important. Every survey, the objective of the survey, the design of the survey need to be very thorough by the users.
Sir, is it
And then, yeah, go ahead.
Sir, is it necessary to mention the name of the hospital, because hospital owner doesn't want?
Sorry, hospital?
Because जो हॉस्पिटल्स के ओनर हैं वो नहीं चाहते कि उनका नाम आए, but they are willing to give.
Each type of understanding mat jao, when everything is on a very fair way, very transparent way. Because कल अगर आप कुछ predictions दे दिए and the hospital responsibility नहीं लेना चाहते हैं, तो फालतू unnecessarily आपका time waste हो जाएगा, and then nobody going to stand for you. You means the research for the researchers. Because the purpose of any research, the main purpose of researchers should be always speaking the truth. Truth in a sense, their aim is to आप model build किया, model का outcome है, outcome बता रहे हो, तो आपका purpose है कि just whatever it is the fact, you tell that. Don't worry about the consequences.
Okay, sir.
Then what happens is the researchers have to be also, they have to be enough daring to tell the truth that I don't know, or this cannot be done, or this is the truth. Then only the science will advance. One cannot conclude just for the sake of the hospital managers, or if that is the case, that let us don't have to that kind of collaborations which are not healthy. That's why better go to the government websites and the public available data if the hospitals are not willing to share.
Okay.
But they share, everywhere, there is a variety of individuals are there. We need to go through a proper individual. That's what the goodwill. When you have a good network, then automatically they support your work, and then all these things happen. The patients also needed. We need to have a little bit of patience to go through that. These are all not easy thing, but ideally they should happen. हो जाएगा, one hospital, not other hospital.
Okay. Thank you.
Welcome. Any more questions? Feel free to ask anything, because some of the questions are not related to the course what you are asking. Feel free to ask questions. So don't give up good research. Always there is a value for good research. Maybe it's a short time or long time. Each research done with a dedicated mind always will have its own benefit for the society.
Excuse me, sir.
पूछिए.
Sir, you have done a very good presentation, very good explanation for all the models you have explained. You have used this data for medical sciences.
Uh-huh. Thank
May
you.
we request you to prepare at least one model, how you reached up to the publication, starting from the scratch with the data, step by step, how you analyze the data, which steps you have taken, which software you have taken. Is it possible to find out a, because before publication article, it's okay, published article is there, but how it was derived, how it was analyzed. Is it possible to have this type of some article where we can have step by step? Because anyway, we will be listening your videos very frequently, so that it will keep on refreshing our memory. But is it possible to have any document where all at least one model is explained step by step, how reached?
Correct. Yesterday, in the list of, did you read the list of articles sent by Professor Kumar on the HIV? Did you receive that file with all the articles I sent in one file? In that one article, did you receive? Did you see that there? I will send that. I will. I mean, if not, I will send it again. In that, he shared with all of you one article in 2003 sometime. It is about the construction of the mathematical models, how to construct, and various steps involved in that. That is explained there. And regarding the how I did the various things, there is a one interview done in a magazine called Connect. By the Connect is a magazine published by the Indian Institute of Science. So they interviewed me, and then the journalist wrote, we asked various questions about how to collaboration to be done, all these things. And there is a guest editorial by the journal Current Science. In that guest editorial also, two editors wrote how the HIV models, public health work benefited what have done the government of India, all that various interviews. But you are right, I have not touched that aspect of the collaboration more. I mean, based on the questions I answered, but some other time is about the collaboration. It is interest has to come from both the ends. I appreciate your question. I really thankful to you for that nice question. Appreciation. The interest has to come from both the sides. That's the purpose of this design. The design, as I mentioned, they could have designed MDU, could have designed the just stochastic process course, but they designed this course to help all the participants, because the basic science historically आप देखोगे तो India, historically India में बहुत कुछ हुआ which are applied and theory both. As yesterday Professor Kumar mentioning, the pi value, just this out of medical science, the value of pi Aryabhatta when he computed, no one in the world, that 5th century AD, no one would know that 20 एक दिन में दिन रात होता है, दिन होता है, ये सब everybody knows it, but he showed that in a day there will be 23 hours, about 40 minutes. He computed mathematically. He developed the model, astrological model, and computed, showed that. And he showed that also the value of a pi up to 5th decimal point. Can you imagine 5th? कंप्यूटर में कंप्यूटर का कुछ क्या, कंप्यूटर 1950 में कंप्यूटर्स का कुछ डिजाइन हुआ था, एंड आर्यभट्ट 5th century AD. So the computation things, not only theoretical things, computational things बहुत एडवांस हो गया इंडिया में 5th century AD में. But then after that, the historically invasions, India was under various occupation by the British. So इधर destroy हो गया. Then we think that now only thing बाहर जो होता है वही सही है, अंदर का कुछ नहीं है. That is the assumption in everybody's mind injected, which is wrong. Everybody can think. Publication के बाद छोड़ दो. Basic science सोचने के लिए everybody has दिमाग, no? What is right model? What is wrong model? कितना क्या चाहिए? You develop the things, doesn't work, you develop another model. बस उतना ही है. There is no distinction between math, stat, physics, कुछ नहीं है. आर्यभट्ट जी के टाइम में there is no distinct field. There is no STEM. Everyone can do anything, provided they have a interest and learning capacity and time they want to spend. ऐसा कुछ नहीं है. Anyone can do good work. They can start it. Only thing they need inspiration. They don't have to do. Somebody else can do. We can make it. No. So that's the example I gave in that CBSE kids. When they asked the NCERT asked me to give a talk on modeling for the high school kids. I recently with that 3-4 महीने पहले वो भी YouTube में है. Anyone I gave a talk in Hindi that time, because I want to reach a wider kids. तो इसको like that, the modeling, mathematical modeling, historically India कहाँ develop हो गया, the भारत में, even the Pythagoras, the values are there. The root 2 is irrational, or the Pythagorean triples, 3, 4, 5, all these things, they were used during Sulabasutra period, much before Pythagoras was born.
Yes, sir. Yes, sir.
वो इंडिया में था. तो इनफैक्ट आज दोपहर को दूसरा टॉक दे रहा हूँ. माय कोलैबोरेटर स्टीवन क्रांच, जिनका 70 years celebration पे, he is a complex analyst. I'm dedicating an article on complex analysis to him. In that I'm going to explain also various things. Today afternoon I'm talking. Monday also I'm giving another talk on that. Monday there is John Conway करके है. He died due to COVID. 83-year-old mathematician. So I was asked to give a lecture on his name. So Monday, that article dedicated to my collaborator who finished 70 years. So there also I'm discussing the ancient things, and then also my contribution about complex analysis. Anyone can do anything, just inspiration. You are all I'm really thankful to all of you for being so serious in the course. Itna serious, wo bhi raat ko, evening time. Yeah.
Sir, can I ask one question?
Yes, please.
Sir, my question is that whenever we plan a research, the emphasis should be on originality and novelty.
Correct.
How can we ensure that the problem is novel? And that too in with the application, if the research is planned with application in some area.
हाँ, वो तो you have to first design your mind. आपको पहले one has to decide what to be done. It's a good question again. How to decide somebody else? So आपको पहले idea पूरा उसको design बनाना चाहिए. उसके बाद you implement, test it, and sometimes you may not know somebody has done or not. Sometimes your guide might tell you, if a student, your guide may tell you, or if a colleague, or sometimes you submit your journal article and journal will tell you, or you Google through that after you design your part. And you try to you come to conclusion somebody else done. If it is exactly similar or different, then you tell that this is being done, but this is different here. So that's how you build your motivation. Initially, ab introduction likhoge article mein. Introduction speaks about how this work is novel. है ना? आप introduce it, then who all done what all work and how my work is different. That's how you promote that's how you argue. Build the argument. You don't argue, you build the argument.
Yes, sir. But sometimes we are not able to get all the papers written in that area.
Then you don't worry. जब अब पता नहीं तो क्या करोगे? Submit it.
Right, sir.
You don't have to spend several time in कोई कुछ किया. अगर really कोई नहीं किया हो तो you have to first decide इसमें क्या novelty है, and इसमें क्या model data क्या, what is the translation? Because model is a translation of the
real world.
reality.
Yes.
Reality. तो translate कर रहे हो, बस आप कितना close translate कर रहे हो, you will know it, because आपको पता है data fit कर रहे हो, mathematical model. Somebody told yes, COVID not predicted well, तो आप correction factor करोगे ना.
Right. Thank you, sir.
Welcome. So list of articles again that whatever I mentioned, I will going to send that again to Professor Kumar. Perhaps some of you not, because I know you are working hard every day and night. Your evening learning the course, and daytime you are practicing the lecture notes, whatever you are doing. It's 5 days have gone, so I will send that articles again. So if there are no more questions, then we can, Professor Kumar, Professor Redu, they can take a call to close the session, or up to, I'm available here. and you all done well for the test. Don't worry, that's only for test your understanding. You all bright, but just to sake of for the Gyan purpose, I designed all the questions to so that you all can think again of what happened. You all must have done correctly.
Okay. So, thank you so much, sir, for your valuable suggestions and inputs in this program and your learning. My
Thank you.